Dr. Ramu, what time do you have for you? I have 8:57 a.m. Eastern Time.
I have 8:57. I think maybe if we target a start of 9:05, that would be perfect. What do you think? Or 9?
I would start at 9 and take our time with
Okay.
our questions.
Yeah, a few minutes then.
Thank you.
No problem.
I also have the live kind of audio on X in the room that I started.
Oh, perfect.
But in any case, we'll transmit this later, as you said, as a recorded webinar.
Badria, good morning. How are you?
Hello, good morning.
Morning. Good to see you.
Good to see you too, Ramu. How are you? Otar, how are you?
How are you, Dr. Badri? Nice to meet you.
Nice to meet you too.
Okay, I have 9 a.m. And this meeting is being recorded. Good morning, good evening, everyone. My name is Ziad Kazzi, and I'm honored to participate in the International Lead Poisoning Prevention Week that's organized by the World Health Organization. This is the week, October 20 to 26, 2024. We are contributing with a case-based discussion of lead poisoning. It is Monday, October 21st. And this is organized today by several partners and organizations, the Middle East and North Africa Clinical Toxicology Association, for which I serve as the co-director currently. This is also organized by the Nepal Poison Information Center that is represented heavily today by participants as well as our speakers. So I'll let them in a little bit tell you more about their poison center, as well as the Oman Poison Center represented by Dr. Badria Hatali. We'd like you to participate on social media as well, if possible, using X or Facebook or Instagram. Remember, the hashtag lead poisoning is being used by WHO. Feel free to tag us, including at Menatox. Also, I'll take the opportunity here to invite you to join us in Muscat, Oman, for our annual Menatox conference at the Sheraton, Oman, February 23, 26, 2025. You can learn more about our conference at menatoxconference.com. This is not the first time that Menatox participates in the WHO Lead Poisoning Prevention Week. We have been regular participants over the last couple of years, and this year, again, we've registered our event under Nepal this year because you can only select one country, but this is a Nepal, Oman, and Menatox event registered on their website. And we've been announcing this involvement throughout social media as well as our newsletter that we've released earlier this month. Just to, again, reiterate, this is going to be a case-based discussion with several people that are participating. We gave it 2 hours on purpose because we want to really take our time in discussing this and sharing ideas and challenges and solutions. So this is going to be a little bit of a interactive session, although we do have about 120 slides to go through, but the slides are not the most important thing here. It's more the discussion. Again, my name is Ziad Kazzi. I'm a professor of emergency medicine and medical toxicology at Emory University. I'm the assistant medical director of the Georgia Poison Center, the director of the International Toxicology Program at Emory, and the co-director for the Center for Advanced Emergency Care at Emory University. I am the past president and current director of Menatox, the vice president of the American College of Medical Toxicology, and I have a clinic at Grady Hospital that takes care of people exposed to environmental and occupational toxicants. This is something that we'll bring up during the webinar about the role of these outpatient clinics. And last but not least, I'm a consultant for UNICEF Georgia on their projects related to lead poisoning that we will discuss in the webinar. I'd like to also introduce our speaker from the Oman Poison Center and Menatox, Dr. Badria Hatali. She is currently the president of Menatox and heads the Oman Poison Control Section at the Oman Ministry of Health, Department of Occupational and Environmental Health. She is a consultant in emergency medicine and medical toxicology at the Royal Hospital in Muscat, Oman. Dr. Badria Hatali is one of our experts in the region in environmental health, trained in medical toxicology at Emory University, and will share latest updates from Oman regarding lead. We will also be joined by Dr. Randi Smith. She's an associate professor of surgery, the vice chair of diversity, equity, and inclusion in the Department of Surgery, Division of Trauma, Emory University School of Medicine. She's also an associate professor at the Emory Rawlings School of Public Health. She has a deep interest in public health and injury prevention, particularly gunshot wounds and how that relates to lead poisoning. So we will actually discuss that with her. She is currently today on call for the trauma service, so her presence with us will be intermittent. But whenever she's able to join us, we are going to tackle the issue of retained bullet fragments and lead poisoning, something that we see a lot of at Grady in our hospital in Atlanta, unfortunately. And we are working on improving our response to this issue. We have several collaborators I would like to list. Of course, Dr. Ramu, Kharel, and myself, we are faculty at Brown University and Emory University, respectively. And we want to acknowledge our affiliation to these two great institutions that focus on global health and public health and injury prevention. Other collaborators that are participating in this campaign, we have Caucasus Medical Center in Tbilisi, Georgia, with Dr. Ottar Dikhaminja, who's a medical toxicologist and head of the emergency department at Caucasus Medical Center. He is a vice president of the Georgia Emergency Medicine Physician Association and currently a level 3 clinical toxicology certificate program candidate at Emory University. He's been also participating in advertising this event, part of the WHO campaign. I want to also welcome Dr. Vildan Ozer from Karadeniz Technical University in Trabzon, Turkey. She's an assistant professor of emergency medicine and a level 3 clinical toxicology certificate program candidate at Emory. From Kyiv, Ukraine, we have Dr. Vladislav Kravchenko. He's a resident in internal medicine at the National Research Center for Radiation Medicine, Hematology and Oncology in Ukraine. He's also the founder of the NGO CLATS Education and a member of the Bellagio Global Health Education Initiative. He's currently a level 3 clinical toxicology certificate at Emory University. We have additional honored guests from the Ministry of Health and Population of Nepal that I will ask Dr. Ramu to present shortly. And I also want to acknowledge the participation and collaboration of Dr. Robert Geller, Professor of Pediatrics and Medical Toxicology, and the Medical Director of the Georgia Poison Center and Emory University. I would like to then turn it over to Dr. Ramu Kharel, who's a collaborator and friend and colleague for many years. He actually trained in emergency medicine at Emory University and currently is an assistant professor of emergency medicine and global health at Brown University in Rhode Island, USA. He's also the founder and international principal investigator of the Nepal Poison Information Center and the founder and chief strategist of HAPSA Nepal. Dr. Ramu, I will turn it over to you.
Thank you, Dr. Kazzi, and thank you everyone for joining this one of the first events as we kick off the International Lead Prevention Week today, early in Monday over here in Rhode Island. I'm really excited to have so many people from around the world, around the different parts of Asia, as well as outside of Asia as well. And we have really nice collaboration here with Menatox, as well as the Oman Poison Center. So really excited to hear about the different aspect of lead poisoning that we'll talk about today. Like Dr. Kazzi said, my name is Ramu Kharel. Over the last year, we have been running Nepal's first Poison Information Center, and we're gonna start today here with a case from Nepal. Our first person who will be talking about the cases after I talk will be Dr. Rajesh Sharma. He is our lead spy from our Poison Information Center, the first spy of Nepal. He is at the Tribhuvan University Teaching Hospital, which we collaborate to implement the Poison Center in Nepal. So he'll be presenting a case. And we also have a special guest who has joined us from Nepal at kind of a last-minute request, despite his busy schedule. So I'm really thankful for Dr. Samir Kumar Adhikari, who's also here. He's a senior health administrative officer in Nepal. He has done tremendous work in the country throughout the COVID pandemic. He was the leader of the Health Emergency Operations Center during that disaster. He's currently at the Ministry of Health, and he will sort of tell us about the national priorities around lead poisoning and what's been going on in the country as far as that. So without further ado, I'm just going to kind of give you a brief scenario and overview of lead toxicity in Nepal. Thank you so much. All right, so really, epidemiology of lead toxicity is it's quite a high burden, especially in pediatric population in Nepal. And this is kind of consistent with other low middle income countries in the region as well. But there are some interesting items where lead is found in Nepal. First, there have been cosmetics like lipsticks and things like that, which are seen in other countries as well. Most of the lead exposure in Nepal has been through paint, as it has been in other parts of the world as well. The government kind of has a 90. There is a limitation for how much lead there can be. I think it's 90 ppm. But only 50% of the lead that is found in the country is compliant with that. This was since 2014. This has been put in place, and hopefully Dr. Samir Kumar can tell us a little bit more about that. And then a large source is Ayurvedic medication as well. That has been rising over the last number of years, and we see a lot of health providers, and hopefully we have health providers joining from Nepal that can talk about sort of directly kind of Ayurvedic medications that are out in the market and dietary supplements that have high level of leads. Can we go next? Like I mentioned, food and Ayurveda is a big one. And particularly, we have heard this, there's a large study from Bangladesh that brought this to attention a few years ago. But turmeric is a big source of lead, which we don't really have great data from how much lead is in turmeric in Nepal. But we know from the region that's a big content of lead. There are some studies that have been done on rag pickers, like people who work with sort of picking trash around Kathmandu, that have been found to have much higher lead levels than the regular population. And then, of course, other sources like toys and battery, which is known around the world. Can we go next? Here are just a very few studies that have been done in Nepal. Really, the bottom line of this is here, on average, in a study that was done in 2019, I believe, 65% of the children that were enrolled in these are random children at a facility, had higher blood lead level than normal, which is a crazy large amount. Can we go next? And then, of course, the impact of this in Nepal, it's estimated, and this was from 2013. It was estimated that due to the IQ loss, due to sort of losses related to chronic lead toxicity, 4% of Nepal's GDP was estimated to be lost because of this. And then worldwide, we know there was a great paper on the Lancet a few years ago that estimates the economic burden of this, which is around $6 trillion US, which is in par with some of the other high public health burdens around the world. So this is a huge impact around the world, but also in Nepal as well. Currently, and this is when I'm going to introduce our speaker from the Ministry of Health, but as of up to our knowledge, as of now, there are not there's not a single public health facility that does screening around the country. Nepal is divided into 7 provinces, and there is no known sort of governmental or publicly available screening program that I have found. There is a no need to adapt lead level screening in the country, and for government to really work on implementing its law and regulating, especially given that Nepal is one of the half of the countries around the world that has committed in a legally binding contract to lower the import as well as control lead within its country. It certainly has high long-term economic and health impact for the country and the population. I myself might have a high level of lead, which I've never tested, but I grew up in a very small village in Nepal, and I do particularly remember I liked walls and painted walls when I was a child to kind of chew on. So I'm actually excited to go and test myself in the near future. So that being said, I'm going to, can we go to the next slide? I'm going to Dr. Adhikari, are you here? I'm going to ask Dr. Adhikari to maybe speak for a few minutes, just from the government perspective, on lead and sort of lead strategy in Nepal and what's going on in that realm.
Thank you, Dr. Ramu, and good morning, good afternoon, and good evening to all of you that you have been joining. Kumar Adhikari is introduced by Dr. Ramu, and I'm working as a senior in Ministry of Health and Populations, basically for the coordinating for the lead poison as well as the overall environment and climate change issues within Ministry of Health and Populations. Basically, I coordinate for the multi-sectoral issues for the public health related issues in country. And so regarding the lead poison, it's at Dr. Ram list. And today afternoon that we had discussions as well in the ministry, basically for the kickoff of the prevention week for the lead poison. So mostly the source that basically we find that the wall painting, basically that is the number one that I would say is for our discussions. And the second one is the cosmetics. That's the major source in our country, and that the toys for the children, that's the another major source for lead. And of course the food and Ayurvedic medicines, these are the other major sources as well. These are the major sources that's already mentioned by the Dr. Ramu as well. And basically for the interventions or the some activity that's been carried out by the government, that in 2015 June that government set some standards for the food items for paints and some so on. So basically for paint cosmetics it's 10, and for Ayurvedic medicine it should be less than 10 ppm. And for not for all the Ayurvedic medicine, but specific medicines that basically do have the lead in content, so they should prepare without any lead. And if there is, should have to add some component that should be less than 10 ppm. And similarly there is a different in the capacity of the healthcare workers, that there are the many gaps that we have to address. Basically the capacity of healthcare workers and the awareness of the general public, awareness of the I would say the business market, I would say, basically the supply of the toys, supply of the production, and the supply of the paints, etc. So the capacity of the laboratory are also not so in that we can do the screening of all the area or all the children as well. And the prevalence that we see in the blood lead content that varies from the one part to the another part. Basically, if we see the major cities in the southern part of the country, basically such city that we can see the prevalence are high. In one of the metropolitan cities that we found it's nearly 100% children that they do have the lead content in their blood. And if we see in other cities that its prevalence that though sufficient areas, cities or the cities in the northern part of the country that comparatively they do have the less prevalence, but in the southern city that they shows basically the one city, the Birgan city, which is the industrial city as well. In that city, the recent study show that the prevalence is quite high. So from the public health side that we are trying to raise the awareness, trying to raise the. But the good thing is that the Constitution of Nepal specifically mentioned that the right of the public for the healthy environment, that's specifically mentioned. So based on the constitutional mandate that the government can do, government can move forward for other interventions. And in 2015 that some specific standard endorsed by the cabinet, and that's in for we can reduce the balance, we can intervene for the impact of the lead in our public health sectors. For right now, and if anything that I will jump in between as well, or I will clarify if anything that I have to clarify from my side. Thank you. Over to you, Dr. Ramu.
Thank you. Thank you, Dr. Adhikari. There was a little bit of issue with connection, but I think we got the sort of the message that that you're sending with the where the prevalence is in the country, what is the current sort of priority of the government, and it looks like you're saying this, and when the Prime Minister of Nepal was here a few weeks ago for the UN summit in New York, we had a chance to meet with him, and one of the things that was mentioned was lead, and he actually gave an entire talk at the UN summit regarding the burden of lead in the country. So it definitely does sound like falls in the national priority as far as sort of tackling this issue. So thank you so much for your inputs on this. This is really valuable for us to know. Next, I would like to invite now Dr. Rajesh Sharma, who I think most of you are very familiar with from his involvement in our Nepal Poison Information Center, the lead specialist in poison information. So Rajesh will now present a case that has presented to the Nepal Poison Center on lead.
Thank you so much, Ramu, Dr. Ramu. So we only got one case of lead poisoning in our poison center, which I'm going to present to you today. The 30-year-old female, she visited to the OPD, outpatient department, with complaints of fatigue and weakness for about 6 months. There was no history of fever or recent travel, weight loss, cough that we could find. On vitals, she had tachycardia with heart rate of 110, but otherwise stable. On examination, she had pallor and jaundice. So the treating physician, they send the CBC, complete blood count, and basic metabolic panel. So what we found was hemoglobin was 6.9 with microcytic anemia picture. Bilirubin was high. So we plan to admit the patient in the hospital and provide 2 pint of blood transfusion for her low hemoglobin. And also at the same time, we were trying to get multiple histories, and we couldn't, really find what could be the cause of low hemoglobin, because there was no any blood loss picture coming up from the history. So we sent the lead label as well. The blood lead level came to be 53.97, which is way a lot more. And we prescribed, I mean, chelation with DMSA or Saximer, and we already provided blood transfusion. Next slide. But the problem was that we couldn't find Saximer in pharmacies and hospitals around Kathmandu. So we searched the whole day. We mobilized our team throughout the country, but we couldn't find Saximer in the country, which has been a really big challenge in the treatment of lead poisoning, I'll say. Eventually, the patient didn't get Saximer, but followed up after a week at the hospital. Hemoglobin improved with blood transfusion. Patient was discharged because we couldn't find anything, no source of loss of blood from the body. So the patient followed up with the hospital after a week. The hemoglobin improved. On detailed exposure history, we found that she has been taking Ayurvedic medicine for the last 2 years for some bowel problems. And also she worked in the textile industry in India for 2 years, which was 8 years back. And another was we just suspected, possible contaminants. It could be lipstick or like turmeric used at spices. She didn't have any pica behaviors. There were no one in the family that had elevated lead level, so we thought it could be some exposure related to either industrial or some Ayurvedic medications or maybe lipstick, because it was only her that the lead level was higher than expected. Next slide. Yeah, so I think to tackle the lead poisoning in Nepal, these are the areas that we need to work on. So one is blood lead level, because not all public facilities have this. Only few private labs, they have this facility to measure the lead level in the blood. So I think we need to reach these facilities to all across the country. Other was to ensure the availability of the chelators in the treatment of lead poisoning, because as we encountered that we couldn't find chelators like Saximer in the big hospitals of Kathmandu. So I think we need to ensure these things so that we could treat the lead poisoning in Nepal. And others are, there are, like the lead poisoning in the country is, I think, underreported because we haven't extensively tested the levels of lead in the blood. As we know, there has been limited studies in the past. So I think further studies in identifying the source and also like in the treatment of those identified needs to be done in the future. I think these are the areas that we need to work in the country. And this concludes my slide. So thank you.
Thank you, Rajesh. I think you we haven't, it's hard. We haven't seen many acute toxicity from lead at the poison center, but mostly there's a high burden of chronic lead toxicity, as you have kind of alluded to, and biggest challenge with testing and with finding of the chelating agents, which is a really big challenge. So if Dr. Adhikari or others in Nepal that work have a few comments on this, on sort of finding this chelating agent, like what issues you're having or where you can find it and testing, and you want to say a few words, you can, before I hand this over to Dr. Kazzi. Back to Dr. Kazzi.
Hi, may I speak?
Yes, please.
Thank you.
This is Ananta. I'm from Nepal. I'm basically a clinician, so I was invited by Dr. Ramu. So basically, I work as a gastroenterologist and hepatologist. So one way that we come across lead is acute poisoning with, or even chronic poisoning with, pain abdomen. Now, if I have to define how lead poisoning has been evolving since a couple of years, my first case that I encountered lead poisoning in Nepal was about 10 years back. Ever since, I got nearly about 1 or 2 lead poisoning cases every year or so, not more than that. But this year, during the last couple of months, like for 5 months, we encountered almost an epidemic of acute severe lead poisoning. And one thing that we could relate was use of commercial supplement that was used for weight loss. But basically, this was an Ayurvedic preparation based on Garcinia cambogia. Even though we've actually quantified lead levels in those products, but that has been a common denominator across all the cases that we've come across. And interestingly, there are 4 clinical features that were very common among these acute lead poisoning. First was pain abdomen. Second was derangement of liver function, especially they can have bilirubin as much as about 5 or 6 milligram per deciliter with transaminitis. Third was constipation. The constipation was very predominant. It was found in almost all the cases. And fourth was anemia. This could be normocytic, normochromic, or even microcytic hyperchromic anemia. So in my practice now, if I come across these 4 symptoms in a patient, then the first thing that goes in my mind is lead poisoning. And almost all the cases that I came across, maybe 9 or 10 cases this year only, so everybody had lead levels more than 65. So that was pretty much high. And I agree that succimer is not available. We tried to search for that, but then we found a way out treating this patient by using D-penicillin. It works pretty well, and that's actually a second-line agent. So we are very familiar with using D-penicillin for Wilson's disease, and so it was not much of a problem adapting the same protocol for treating lead poisoning. And a couple of my patients during follow-up, the lead levels are coming down gradually, so which is pretty appreciable. So it probably will take about 3 or 4 months after proper chelation, and I think the lead level is going to come down.
Thank you, Dr. Anand. That's a really good perspective from from your personal clinical experience as well. And it's really concerning that over the last few months things have looked even worse. So I hope I think there needs to be a lot of work from the public health side of things that needs to be done in policy as well as education awareness effects. But yeah, thank you for your thoughts here. Is there anyone else that want to put, maybe one more person from Nepal that want to add to this discussion who might have experience with lead in the country? Anjana, you want to unmute? Yes, Anjana would like to say something.
Hello, Ramu.
Oh, it's Kabin. Okay, Kabin, please go ahead.
Can I have a few words?
Yes, please go ahead.
Hello, everyone. So it's me, Kabin from Axe Foundation, a collaborating partner from PIC of Nepal. So as Dr. Anand have said, like we have as a pharmacist and also a central committee member of Pharmacy Association of Nepal. So we have came across with some of the requests from few hospitals regarding the request with chelating agents, especially focused for lead poisoning and heavy metal poisoning. So within like a few weeks, and we have realized that we have a very high cases being reported from different hospitals, and it hasn't been like documented so far. And apart from that, like there is like a lack of chelating agent in Nepal. Hardly like we have one chelating agent, despheroxamine, available, that too with a provisional license for a couple of months. So we have that scarcity. So we have spoken with some of the stakeholders like Department of Drug Administration and some of the like medical colleges for the availability of those chelating agents. So hopefully we can get those chelating agents as soon as possible from the importer, and Department of Drug Administration or regulatory body in Nepal, like FDA and USA, they have assured that they will expedite the approval process for the approval of chelating agent, at least for a small quantity, and hopefully we can make the chelating agent available for all over the country. So, and for now, like as Dr. Anand have said, the unregulated market of those food supplements and herbal supplements in Nepal, we assume, we don't have the concrete evidence, but we assume that a major source of lead for chronic poisoning is from those herbal and food supplements that is rampantly being used through and marketed through the online media. So we hopefully we can advocate for that in near future. Thank you.
All right, thank you so much. Okay, I'm gonna as we're running short of time, so Dr. Kazzi, thank you so much for that discussion from Nepal. Dr. Kazzi, I'm gonna hand this over to you. Thank you so much.
No, this is great. I mean, this is actually, we're fine on time, Ramu. I just wanted to say that he just gave me a great segue for what I was going to talk about. I think the first message is that lead hazards or lead poisoning or the environmental hazards from lead or this project for the government of Nepal and every government around the world is probably one of the highest rewarding projects because lead is a problem that we know causes significant adverse health effects. We know that there's no controversy about whether lead is dangerous or not. Number two, it affects a large number of people. So it's a problem. It's a problem that causes a lot of problems, as you pointed out, Ramu. And finally, we know what to do about it. We can solve it. So for any Ministry of Health listening today, lead problems are a winnable battle. And I hope we all take up this mission to win this battle in our own communities, in our own countries, depending on our role. And I'm going to start by sharing with you my story with lead as an example of how a government, a community, can rise to this occasion and deal with it. I start with my involvement in the Republic of Georgia and Tbilisi. My wife is Georgian, so I started visiting Georgia as of 2012. At that time, as every medical toxicologist, we always look for lead issues because we really specialize in managing lead poisonings or preventing lead poisonings. And I've, done the same thing as many other toxicologists, asked the question in Georgia, what's going on in this beautiful country? Is there any research on lead? And all I could find was a case report in 2005 published by a colleague of ours, Dr. Alan Wolf in Massachusetts, who took care of a Georgian family in the US that was lead poisoned, but had been eating spices from Georgia. They brought the spices to the US with them. That was the only case report that I could find in 2012. So I decided to do a convenience-based study like you all shared, like Ramu, you shared recently. And I encourage our colleague from the Garcinia Cambodia outbreak to also, collect this data and publish it. So that's what I did. I did a convenience-based study. And in this study, I identified a 3-year-old boy with a blood lead level of 57 microgram per deciliter who suffered from significant developmental delay. And the study was published in its abstract form at the North American Congress of Clinical Toxicology. And we showed in our study that about 10% of our population studied of children had blood lead levels greater than 10 microgram per deciliter. And of course, the highest level was that child with 57 microgram per deciliter. That's great. So that's the first lesson, is to do these kind of studies. These are good studies. They're easy studies to do relatively. And you can get some data about where you are. So I encourage people to think about this type of publication as a starting point. The second thing I want to talk about is the next step is you got to go and investigate the source of these exposures. It's not enough to just collect blood lead levels on people without adding to this a source investigation or exposure assessment, like you've done in some cases that you presented in Nepal. In my case, I went to the home of that child and I collected samples of paint, soil, water, and I did an exposure history, collected spices as well. In that specific situation, you see the pictures of that child's home. This is the door of his apartment or house, and this is the window seal of his house. And I thought the water would be contaminated because they used a faucet in the garden to drink, and it looked in pretty bad shape. I was like, maybe this is a leaded pipe, but the water was clean. It did not have any contaminant. So I found the very high contamination level in the paint collected from this door and from this window seal. So in this case, it was paint that caused this child's poisoning. So again, the lesson here is conducting these convenience-based studies is not a bad thing. They're easy to do. They give you some valuable information, but you have to follow up with an exposure assessment. But just this one study raised awareness in the country of Georgia about the problem. This one study that we did, it took us 2 months to do it, raised significant awareness, in addition to the case report that I showed you from 2005, and a few other nonprofit organizations that were doing some studies on lead in toys. All of that created enough energy at the government level to do a proper national study. And this is what I want to also share with you. with the support of UNICEF. And in this study with UNICEF, we were able to get better data, and I'm going to talk about that in a little bit. Now, one issue that we had with this study that I did was that we used the Lead Care Analyzer. The Lead Care Analyzer is a point-of-care machine. You can get a point-of-care test, and you can get a rapid answer for your blood lead level. So this Lead Care Analyzer uses capillary blood, and you can get an answer right there about the blood lead, the capillary lead level. We used it with a venous blood sample. So we used a venous blood sample because it was a convenience study. We had the blood from the vein of the child, and we used it in this machine. And this machine was being used that way at the time. It was not something we did that was unacceptable. It was acceptable, and we did it that way because we wanted to get a venous sample, which was usually better than a capillary sample, and we also wanted to use this machine for that purpose and use blood that's collected already in these children at the hospital. It was a convenience study. But unfortunately, right after we published our data in this abstract form, the company that makes this Lead Care Analyzer and Magellan Diagnostics had a recall because they were concerned that their results were not very accurate if used with a venous blood sample. Not as if used as a capillary test, but if you use a venous blood sample, this company said your results may be inaccurate. So we couldn't really proceed with the publication of this research because of that issue. We knew that those inaccuracies were probably small, not that huge problem, but we couldn't tell for sure, so we couldn't publish this. So we repeated the same study, again, using the gold standard, which is ICP-MS testing. And we found similar results. So we felt reassured that our results were correct, but we also felt the need to do a national study. At that time, the government and UNICEF were collaborating, and we were able to include a venous blood lead level on children enrolled in the multiple indicator cluster survey that UNICEF organizes all around the world. This was a first. Usually the multiple indication cluster survey that UNICEF does not include blood lead levels. It usually includes other questionnaires for the children, other testing for nutrition, etc. We were able to advocate with the government of Georgia to UNICEF and UNICEF Georgia to include venous blood lead level testing for the first time ever around the world. And we used the Italian Ministry of Health, Ministry of Environmental Health support to get the ICP-MS testing on those blood samples. And our results were very significant and very important for the country of Georgia. This is a proper sampling method of the population of Georgia and children. So this is a nationally representative sample. And we found in Georgia, 41% of children had a blood lead level greater than 5 microgram per deciliter, and 16% of them had blood lead levels greater than 10 microgram per deciliter, which is very elevated. Even more, in some parts of Georgia, we found 85% of children had blood lead levels more than 5 microgram per deciliter. So that's extremely significant. And again, severe results when you use the 10 microgram per deciliter as a cutoff. So that's an example of a national study that should be done in every country that needs to have this done. And the support of UNICEF in this was incredible. So I encourage you, Nepal, other countries around the world, to connect with your Ministry of Health, connect with your UNICEF country office, and see when is your next mixed study. When is the next time you're doing a multiple indicator cluster survey study in your country? Because those are periodic. And then you can maybe see if you can include in this a venous blood lead level module to get this nationally representative sample. If you can't do that, you can also do your own national study. We don't necessarily need the UNICEF to do this. You can do it on your own through other sources of funding. But this is the kind of data that is the next step after you do these convenience-based studies. And of course, this seems to be alarming. And however, when you interpret the results of the Georgia study, remember that the US was similar to that situation in the past. And we know that we've been in this situation in the past. Even now in the US, we have some states that have a higher prevalence than others of elevated blood lead levels. But again, we know in the US, because we conduct these national surveys on a regular basis, and we know that we've been able to lower the percent of children that had elevated blood lead levels over the past 2 to 4 decades. And you see in the US, we've had a success story with lowering the blood lead levels, which used to be in the 16 microgram per deciliter in the 70s, and now has dropped to very low levels, even less than 3.5 microgram per deciliter. In the US, only 2.5% of the population of children tested have blood lead levels that are greater than 3.5 microgram per deciliter. So again, I say this because you can see from this graph how public health policy, and I thank Mr. Samir Aderchi for being here with us today, because your role in this is essential, crucial. Because all these policies that you enact on lead in paint, lead in gasoline, and lead in Ayurvedic medications, in food products, in nutritional supplements, in pipes, in water, in air, all of that you can do, you will lower the blood lead level the same way other countries have done over decades. And it's a winnable battle. So I encourage everyone to engage in this battle. So at this point, I want to just do a quick overview about sources of lead exposure beyond just Nepal, and ask a couple of colleagues to participate, such as Dr. Badria Hatali, as well as Dr. Randi Smith, to get their perspective. But lead essentially is a metal, and I want to just quickly point out that we're talking primarily today about inorganic lead. We will not talk about organic lead because lead in gasoline has been removed in probably every country in the world that we have data from. There was some lead being used in gasoline still in North Korea or some in Iraq, but that's been removed as well recently. And Myanmar, I believe, was also reported to have lead in gasoline. Now, there are some still types of gasolines that contain lead, organic lead, but we will not talk about those today. We will focus our attention on inorganic lead. And this inorganic lead that you mentioned in turmeric, Ramu, is probably lead chromate because it has that nice orange color. There's also lead acetate, which is sweet tasting and is what you probably will see in paint. There's also lead oxide, which is red. And then these paint pigments are popular because the colors are beautiful. Also, this lead paint is resistant, is a good paint to use, especially when the environmental conditions are harsh. So using it outside structures, is better than unleaded paint. That's why you see people making leaded paints. It's also present in the solder of pipes. It used to be in pipes in the past. It's also used, of course, in medicine and radiation technology and batteries. There are lead acetate batteries that are still being used, especially with the reliance on solar power, like in Lebanon, where you have a significant economic crisis and issues with generating electricity. So people have their own solar panels and use a lot of lead acid batteries. So all of these environmental conditions and occupational exposures can lead to elevated lead levels, whether it's dust, paint, in the soil, water, air, and food sources, whether it's occupational, people that work with batteries, people that work in smelting different metals, crystal glass makers that are working with making beautiful glass ornaments, people that work with repairing beautifully painted glazed glass. I've had several people that work in firing ranges, or even use the firing range because I like to practice their target. They get elevated blood lead levels. You have people that make their own lead bullets that can get exposed. Welders that use lead in the solder. Painters, of course, that peel off old paint that can be contaminated with lead or use lead paint. And we've had a major epidemic of lead poisoning in Nigeria in people that were extracting gold from ores. They've had a huge outbreak because they improperly, handled these ores and tried to extract the gold in their homes. And hundreds of children died from this lead poisoning outbreak in Nigeria. So remember, gold mining is an important one, smelters, and then don't forget about the gun firing ranges. At this point, I'd like to maybe pause for a second and switch gears real quick to a case we had at Grady recently that I collaborated with Dr. Randi Smith on. Dr. Randi, are you here?
Yes, I'm here. Can you hear me okay?
Yes, I'm going to just present our case real quick because I know you're on trauma and you may have to go and work. So we'll just go through this case. This is a 22-year-old woman that had multiple gunshot wounds, and we've had a blood lead level on her 9 months after her injury, and it was 35 microgram per deciliter. Dr. Smith is managing this case currently at Grady, but I want to just bring up the issue of retained bullet fragments as a source of elevated blood lead levels and lead poisoning. And it's an interesting question because, you know, it's not very well recognized. Would you agree, Dr. Smith?
Absolutely, absolutely. So, hi everyone. My name is Randi Smith. I'm a trauma surgeon at Grady Hospital at Emory University in Atlanta. And, you know, as a trauma surgeon, I deal with this phenomenon quite often. There are a lot of people who have retained bullet fragments after gunshot wounds. And I think historically, we thought about little bullet fragments when it came to military and war times, but we have a real problem in the United States with civilian gunshot wounds. And actually, you know, I think that our problem is on the rise. So we're seeing this more and more. In 2021, in fact, we had the highest recorded firearm-related deaths. There was over 48,000 deaths from firearms in that year. And we know that 2 times as many people survive their injuries, and a significant portion of those have retained bullet fragments. So we're talking about a lot of people who have exposure. And it came to me because I was taking care of patients and everyone wanted to know what their risks were with having these bullet fragments in place. And I really didn't have a good answer. You know, like Dr. Kazzi said, there's not a lot of information out there. And so if there's not a lot of information, there's not a lot of guidelines on what to do about it. So when this case came up, it was very multidisciplinary in our management. We checked a blood lead level. It was elevated, and it continued to rise. So we knew enough to check the blood lead level and to follow it serially. The patient didn't have any major symptoms from the blood lead level, but when you have a young woman, especially of childbearing age, it got us all thinking, like, what is the right plan? Like, what should we do? How should we manage this? And me being the trauma surgeon, I'm like, well, can I feel it? Because then I can go and I can take it out. And I can't take out all of the bullet fragments because you can see just from this x-ray that there are multiple fragments and some were deeper than others. And so I love having these discussions because I would love to know what other people think about doing in this situation. But our big thing was, let's try to take out the bullet fragments that were palpable, that were superficial in a way that wouldn't cause any more damage, but could potentially lower that blood lead level that we were continuing to see rise 9 months after the initial injury.
That's great, Dr. Smith. I mean, for me, like when I think about this problem as a toxicologist, clearly a 22-year-old woman with childbearing age with a lead level of in the 30s is concerning to me. Yeah, it's concerning to me for her childbearing capability, the reproductive health, the reproductive outcome of her pregnancies, infertility and reproductive outcome are going to be an issue at these blood lead levels. We can even see issues at lower blood lead levels, less than 10 microgram per deciliter in some studies in pregnant women. So that's concerning. And this, let's say this was a man, and we are concerned about their fertility. There'll be some effects on fertility in men as well. So remember that again. The third issue is, let's say this was not a childbearing person. What if this was a child? And unfortunately, as you pointed out, we do have children that are unfortunately victims of these gunshot injuries, gunshot wounds, and retained bullet fragments. So that's, of course, that's a no-brainer to me of the need of removing the blood lead, the fragment, the source of the lead. And even at older age categories, you know, at these levels, you know, you're concerned about cerebral, hypertensive disease, kidney disease at these levels. Now, you and I know that these blood lead levels will fluctuate depending on the time you basically check the blood level and what's going on with the patient. So, for example, bone turnover in pregnancy can increase those blood lead levels. There was a recent study actually in Tbilisi done in pregnant women that showed that this wasn't in retained bullet fragments, they were just contaminated with lead some other way. But they found that their blood lead levels increased during different times of their gestation, of their pregnancy. as you progress in your gestation, you'll have higher blood lead levels because of increased bone turnover. But how difficult is it for you as a surgeon to remove these bullets? You know, it's easy for us to say, please remove the bullet, but what comes into your assessment?
Yeah, so first I want to know the location of the bullet. The location is really what drives us. I have removed bullets in my clinic, so it requires just a little bit of a scalpel to make an incision on the skin and then remove it and close up the wound right then and there. They don't need any anesthesia. And sometimes they're deep and I have to take them to the operating room. Or if someone is, you know, pretty squirrely, they don't want to deal with the pain, or, you know, they want to get to the OR and be comfortable and asleep, we offer that as well. But for me, I always think about the location and what the other surrounding structures are. In this situation, one of the bullet fragments was on top of the clavicle. And so it wasn't deep where there were a lot of blood vessels or anything like that, but there were some other ones that were deep. And so when we counsel the patient, we say, I'm only going to be focused on the one that is superficial. I'm not going after anything else where I can cause any more damage. And I will tell you that this management strategy has changed. I will say that over the course of my career, even when I was a student, when I was an intern and early resident, I remember some of the surgeons telling me, we're not going to go digging for bullets. We're not going to go searching for them. We're not going to take them out, even when they were palpable and you can feel them. And I will tell you that we've had a change in our management paradigm because we recognize that not only is there an issue with lead levels and lead toxicity, but also the bullet themselves, the fragment, can be a constant reminder of the trauma that the patient endured. And that can lead to negative psychological consequences. So that's another reason to remove the bullet. So I will also say too, when we think about lead levels, we're often thinking about the symptomatology, and you mentioned some other consequences like the high blood pressure. Neurologic symptoms are another thing that we think about. And a lot of times our patients after gunshot wounds have some of those. So it's hard to discern, are they feeling down? Are they not themselves because of the lead? Or is it because of the sequelae from the injury or the trauma itself? And so I'm constantly thinking about location, other consequences, and that's really guiding my management. It is fairly easy to do in terms of a procedure. You know, we do them in the clinic, but we also do them in the operating room, but we really want to make sure that overall we're not re-traumatizing patients and we're keeping them comfortable the entire time.
Yeah, I agree. And I think, you know, some of the things that we need to do is try to get some better guidelines about which retained bullets are at higher risk of causing elevated blood lead levels. There was a study by McWhirter in Los Angeles that showed that multiple bullet fragments, long bone fractures, presence in a joint, in a
Yeah.
cavity would increase the risk. But I think there needs to be more studies on these, but it's just
Yeah,
difficult.
I agree. I think those are the ones that I think about too. Joints and spine or spinal columns. Anything where it's going to be absorbed by an articular surface, I think really is problematic. And I will tell you that when they're younger and they have longer periods of time for absorption, it also makes me worried.
And of course, we need protocols of when do you draw the blood lead level, how often do you draw it. I think that's important to see, you know, because these blood lead levels, even after you remove the bullet, may take some time to go down because lead will go to the bones. And Dr. Geller maybe can comment on this a little bit about once the lead is inside the bone, you know, and even if you remove the bullet, it may take you some time to drop that blood lead level. Dr. Geller, would you like to comment on that?
Thank you. So first, remember that when lead is absorbed, it moves into the bone and incorporated into the bone, and it will take time. The higher the rate of bone turnover, the more quickly the bone lead will re-equilibrate to blood levels. And so in an area where you have healing bone after a fracture, it's going to turn over more quickly. And so the lead will be incorporated or deincorporated depending on which is higher, because it will reach a new equilibrium with the bloodstream. It's also important to remember that neurologic consequences are not immediate after lead exposure, and so that your neurological consequences immediately after trauma are probably not related to the lead, but they will equilibrate and proceed. So I think that your thoughts about removing bullets whenever feasible are on target, and your comments about proximity to articular surfaces are also in matching with the literature. So I think you're on the right track.
Thank you, Dr. Geller. Stay tuned with us because we're going to need your expertise as well. Dr. Geller has decades, maybe Dr. Geller, how many? 4 decades of experience in dealing with this.
Thereabouts.
Hereabout. So thanks again for being with us today. Anything else you want to add, Dr. Smith? I know you're staying with us as long as possible, but you may have to run to a trauma.
Yes, thank you. I mean, I'm on trauma, but everyone is being so kind and covering so that I can be here. I think this is a very important topic. It's one that I think deserves more attention worldwide, but definitely I think we need to talk about it where in these situations where, for me, thinking about lead in a retained bullet fragment, I don't think that that's something that happens naturally to folks, making that connection. So just bringing awareness about the topic is my number one priority. And like you said, developing some guidelines so that we can have a systematic and standardized way of evaluating those who are at risk and taking care of them. I think that's the way to go.
And I think, our clinic at Grady, so I mentioned that initially. So I mentioned I'm the director of the Grady Occupational Environmental Toxicology Clinic. And we are working already, Dr. Smith and I, with our section of toxicologists on how to collaborate and how to kind of standardize when we send those blood lead levels, she can send them to us to discuss the risk. And we've done this already with this case we share with you. It's not easy. The questions that we receive from these patients are very difficult. Can I still can I go to the gym? Would that elevate my blood lead level? Can I get pregnant? When do I get pregnant? We've had difficult cases where a woman wants to get pregnant, but has a blood lead level of 30 or 40, and she's relatively asymptomatic. But what do we do? Does she get pregnant? I mean, this is an issue. Do you chelate women that are pregnant? Of course, can you remove the bullet? What do you do? Dr. Geller, can you comment on that a little bit? Pregnancy and lead?
Thank you. I was just going to try to raise my hand to answer that, speak to that question. There is no great data, first of all. So there's case data. But the case data we have suggests that all of our chelators are fetotoxic. And so it is generally thought that chelation of a pregnant woman is absolutely contraindicated. I didn't say relatively contraindicated. I said absolutely contraindicated unless because of the high risk of toxicity to the fetus until the fetus is delivered. And at that point, it is possible to chelate an infant and mother postpartum if you were needing to do that. But the likelihood is you will have the risk of fetal neurotoxicity, fetal developmental toxicity from the lead that was occurred during the pregnancy, where lead does cross into the placenta, lead does get into the fetus. And so you would expect that the fetal lead level would be approximately the same as the maternal fetal blood lead level. So if you have a choice, when you have a mother who has a blood lead of 30 or 40, it would be an off-label recommendation, but I would consider chelating the mother prepartum before she gets pregnant, rather than waiting till while she's pregnant or after pregnancy. Again, there's no great data on that, and there's no official recommendation, but that would be my thinking.
There's a paper, thank you, Dr. Garrett. There's a paper that just, special supplement issue from the famous journal Pediatrics on lead in October. I invite you to look it up. It's Pediatrics, October 2024 supplement issue. There has an article calling for universal screening of pregnant women with a blood lead level. Because the current guidelines that exist to whether for a woman to be screened for blood lead levels are non-specific. They're not followed by many people because there's some guidelines. And actually, Dr. Smith, I looked up those guidelines yesterday as I was reading the paper. It didn't even list having a retained bullet fragment as one of those reasons why you would go ahead and test a woman who's pregnant. It's unfortunate, and that's why this paper is calling for instituting universal screening as you screen a pregnant woman for HIV, for hepatitis. I think it's important to do this, to consider this for the OBGYN colleagues out there. I'm going to ask also Dr. Ramu during this webinar to monitor the chat. I'm unable to monitor the chat effectively. If you can interrupt me when there's a need to address some important chat or questions. Thank you, Dr. Smith, for joining us.
Thank you all so much.
So I mentioned briefly battery recycling. So I want to just
Dr.
highlight
Kazzi,
that.
there's a question here from the audience, I think maybe relating to the
Yes.
bullet. So maybe we can have that. Dr. Jivan, please go ahead. You can unmute yourself.
So, yeah, good morning, guys. This is Jivan. I'm one of the internists here at Syracuse, upstate New York. I do have a question regarding the lead, not in particular about the bullet. I don't know, the conversation has already occurred. I had a very interesting patient who had a high lead level, and we didn't know where the lead is coming from. And we ended up, the toxicology team in my hospital recommending doing appendectomy. And that was a very surprising, experience for me. Is appendectomy is a standard practice when you don't know where the lead is coming from. They have a high level of lead. I just want to throw it out there. I don't know, this has been already discussed, or this is a little on the sidetrack.
I think I know about that case. I thought, didn't they have lead in the appendix on an X-ray?
No, yeah, a little bit of light up on the appendix, but there was a lot of conversation back and forth whether it's going to help or not. Didn't have clear history about exposure, and we tried to drill our head left and right, and we ended up doing appendectomy. Finally, we were able to convince the surgeon, because it was hard to convince the surgeon too. I think there were two things. It was hard for me to understand why appendix would be the trouble. And the second question was, it was hard to convince the surgeon to get the appendix out for a lead poisoning.
You should call Dr. Smith, should convince them. Randy, do you want to comment on the appendectomy part? I think this case was just retaining the lead. Somebody the patient must have ingested some lead, foreign body, that was retained in the appendix and caused prolonged absorption there. But let's hear from Randy, then Dr. Smith and Dr. Geller maybe about this.
I have never been asked to remove an appendix for an elevated lead level. I will tell you that appendectomies are one of my favorite operations. But I've never heard of that. It's one of my favorite operations, but it's interesting because we still the appendix is one of those very interesting parts of the body. We really don't know what it does anymore. And we remove it without much infraction, like it just goes away. But I think this is an interesting case that I would love to know more about and see if this is a thing. If we are removing the appendix, I definitely am interested in learning more about it. It's a fun operation, laparoscopically or robotically.
Thank you, Dr. Smith. Dr. Geller, do you have any comment on that? Dr. Hamoudi is also next after you.
So I don't have a comment on the appendectomy question. If there's an embedded foreign body in the appendix, then maybe that's a cause for removing it. But I do have a comment on the occult lead story. We need to remember that lead lasts in the body a long time. And so if you discover it now, that doesn't mean it came recently. It may have been even higher before and not been picked up, because if no one looked, nobody finds. And so it's possible this person had a source of exposure 5 years ago or 3 years ago that is no longer present. So it's sometimes difficult to figure out where it came from, and sometimes we never find out where it came from. But one of the things that's clear is, let's rule out the things that are common. And those are the workplace, the home, and the recreations. And so those things are the places to look. And it is possible the easiest way to look, if you can get the use of one from somebody, is with the XRF device, which can tell you by pointing a wand, you can literally tell what's underneath the direction of the wand. And it works pretty accurately and pretty quickly. So it's really easy to scan a whole bunch of places very quickly if you can get the use of one. unfortunately, are expensive. So their presence is limited. But if you can find somebody who has one, that is the gold standard to looking for sources of lead.
Thank you, Dr. Geller. We have Dr. Hussein Hamoudi, director of the Baghdad Poison Center. I think you've raised your hand. We're ready for you if you would like to unmute, Dr. Hamoudi.
Yeah, thank you, Dr. Ziad. Yeah, I have met one person with lead poisoning. He had subjected to appendectomy. In fact, they misdiagnosed because of most patients with lead poisoning, especially the acute poisoning, presented with acute abdominal pain does not resolve by the usual use of antispasmodic or painkiller. After that, we diagnosed him as lead poisoning and treated with BAL and calcium disodium edetate.
Thank you, Dr. Hamoudi. I know Iraq had lead in gasoline, but recently it's been removed. And I know you have elevated blood lead levels in the population, correct?
Yeah, previously they used tetraethyl lead to increase octane number in oil refinery system. So many cases presented to our center. In addition to those working or employees with multi-unit for batteries manufacturing in order to make lead oxide for automobile car batteries. These are the most two causes of lead poisoning in our country, in Iraq.
Yeah, I agree. You know, this lead acid battery recycling is a big problem. There are a lot of countries that are using this, and children often, as you see here, they get exposed that way. I also pointed out earlier the solar panels and the lead acid batteries that are cheaper than the lithium batteries, so people tend to buy those and use those. I also wanted to point out that recently we had a case in Nigeria, and we have currently with us somebody from Nigeria, I believe, where we had a man working at a lead acid battery factory without using a mask or proper PPE at the factory, had blood lead levels in the 50s. We were consulted on this case with Dr. Tharwat Zahran in Beirut, and we decided to chelate this person and, of course, educate them on how to protect themselves at the workplace with the proper respiratory protection and gloves and goggles and proper industrial hygiene. But we couldn't find the chelating agent Succimer in Nigeria. So we had to ship it from Lebanon to Nigeria. And it's quite costly too. It's not a cheap medication. It can cost, you know, hundreds of dollars to get a course of chelation, which is currently 19 days. Our colleague from Nigeria, do you want to comment as well? I know we have someone from Nigeria, Dr. Ahmed, I believe. If you want to comment, you've had the largest epidemic of lead poisoning in recent years. We welcome you. If you want to raise your hand, we'll give you the floor. Otherwise, I will keep going a little bit with our slides and just highlight some other sources like secondhand smoking and then even third-hand exposure to smoking. All of these can increase blood lead levels, a small amount, but still significant. And then because there's no blood lead level that is safe, as we all know. At this point, I'd like to take an opportunity to hear from Dr. Badria Hatali in the Oman Poison Center about what they're doing. After Dr. Badria Hatali will talk a little bit about lead, I'm going to give the floor to Dr. Awal Ahmed to talk about Nigeria. Dr. Badria?
Thank you very much for this insightful presentation. Really, in Nigeria, we have a lot of lead poisoning, almost, especially in the northern part of the country. But the major challenge, as you highlighted, is the unavailability of the chelating agents. But recently, there is a newly established Toxicology Information Center in Nigeria, which we are pioneers there. So we have started making some contacts with especially South Africa on how to procure the chelating agents, because even last 6 months we have conducted a rapid response action in one of the northern states in Nigeria, where a lot of children were identified to have some lead and other heavy metal poisonings. And there is a collaboration with the Nigerian Center for Disease Control, also with CDC, to see how these chelating agents will be available, especially with this recent establishment of Toxicology Information Center in Nigeria. Thank you.
Well, thank you for this valuable contribution. The patient that we have in Nigeria who works at the factory, they ended up finding a supplement called DMSA, which is Succimer. Now, Succimer, which is what we talk about, is made in by a company called Serb Pharmaceuticals, and in France, for example, it's called Succipital, and they have limited, of course, capacity to produce a lot of it. So I don't know if Dr. Geller has experience with these supplements, because DMSA can be also used as a nutritional supplement by some people, or like a dietary supplement. I don't know if Dr. Geller has any comments on the use of the
supplements are less tightly regulated in the United States than the substances manufactured as a drug. But I can't speak to their regulation or supervision in manufacture outside the United States. In theory, pure DMSA is the same as pure Succimer, since they're identical compounds. DMSA is just a different name. Dimethylsuccinic acid is just a different name for Succimer. So if you had equal regulation, the DMSA supplement would be just as good as the Succimer. I'm not sure how hard either one is to find outside the US, or perhaps some of the other North American countries. So yeah. I don't know the answer to that, but if I had one, I would take it.
That's what we did.
I would also comment that if you really couldn't find Succimer, there is a lot of off-label use and history for many years in using penicillamine as an oral chelator. And that would be another possibility if you couldn't find Succimer and you could find penicillamine. Penicillamine would definitely be better than using nothing.
And that's what our colleagues from Nepal have used in their Garcinia Cambogia outbreak. Thank you, Dr. Geller. I'm going to turn it over now to Dr. Badria Hatali to give us a little bit of an overview of what's going on in the country of Oman.
Thank you, Dr. Kazzi. Well, just to comment back to the Succimer and DMSA, it's usually, relatively the cost play a major role in the stocking of the Succimer, because it comes into capsules at a different, amount, whereas the DMSA usually can be found as a substance, like a powder. And so the cost might be cheaper with the DMSA compared to the Succimer, and probably that's one of the challenges that we are facing as well with the Succimer. I mean, today we just finished also an awareness day about the the importance of knowing about the health effect of lead, particularly with children. And we always emphasize on this. I would say our experience with, detecting how much we are facing in Oman is relatively short, since we started this service for the last almost 3 years now. Majority of the cases that we are facing in kids are mainly due to still traditional medicine use. So we have this kind of traditions that is still there, and it's still being practiced, unfortunately, although it's not as heavy as it was in the past. So probably the largest, I would say, outbreak of lead oxide poisoning happened in Oman was in 1990s, where there was around 25 infants diagnosed with lead encephalopathy. And almost 80% of these children consumed something called bint al-dhahab. And bint al-dhahab in the Arabic word means the daughter of God, the daughter of gold. And that is something that is being used for enriching good health, particularly for kids whom they are failing to thrive, have a low birth weight, or kids that they're suffering from congenital anomalies or chronic constipation. And a majority of the cases that we are seeing right now, probably we don't see much, 2 to 3 cases a year, but it's an incident finding of radiopaque shadowing that is being, discovered during routine evaluation for their persisting condition. And then eventually when we do the test, we find that there is an elevation either for mercury or lead, because these products can, contaminate of both kind of heavy metals. That's the main ones that we are testing. We're not sure if this is contaminated with any other heavy metals that we are seeing. We did not do recently, an evaluation of the content by itself, because most of the patients or the patient relatives, they refuse to bring the material, thinking that might cause harm for the supplier. I would say that's the main source of most of the exposure in our kids. Probably, industrial sources is also something that we are facing here. We're trying to basically find a way to regulate the exposure during work. So this is related basically to occupational health, where we have this kind of screening, and we succeeded to do it for a few companies, and then we are moving forward with the others, where basically we do an annual testing for the workers. That some of them we have, actually detected some of a high levels of lead. It's not the level to cause significant, obvious clinical manifestations, but of course, it's above the level. Actually, things that get, I would say, speed up recently is that there was attention to the environmental health indicators in related to the health. That was being one of the vision for 2040, and basically most of the concerned ministries started to look into that, and that speed up the workup related to the heavy metals, particularly lead and mercury exposures, and that has been done through the Environmental Performance Index by I think it was by Yale University along with Columbia as well, and it was a significant jump in terms of the steps that need to be taken in terms of the tackling health issues related to the exposure to lead and mercury. And I was discussing this with Kazzi earlier. We actually did just a random samples of around 150 kids less than 5 years that we conducted at the beginning of this year. But it was definitely a low sample size. It did not represent the entire population, but just wanted to see, collecting blood samples from different patients presented to the emergency departments. How much is that is going to help us? And we realized that, although 98% of the cases had a very low level, actually even less than 1 microgram per deciliter, but there were 3 cases that has a level more than 3.5. And actually one of them was diagnosed with lead exposure that was not detected at the time of the presentation. So although that is, does not represent the country, as I said, there is, the need basically for, having sort of legislation in terms of the use of such products, as well as the, finding a way to do a national screening for kids at a certain age, basically to detect these cases. That is hard, basically, to be detected without doing a national screen. And that's been a grant that has been submitted already to the ministry and the higher authorities, and we are waiting for their final approval, basically, to start a national screening by the beginning of next year that will involve all kids below 5 years of age.
Thank you, Dr. Badria. Appreciate you.
Yeah, yeah.
Okay, and again, here's the bint al-dahab actually that Dr. Badria mentioned. Kuhl is another one. And spices. In Georgia, in the study in Georgia, we investigated the top 18 subjects in our study, in the mixed study. The 18 homes were visited and tested. In that specific situation with those 18 homes, we found the source of the contamination was spices. So I can't highlight enough the dangers from spices that are contaminated. Even in the US recently, we had an outbreak of lead poisoning from cinnamon that was contaminated with lead chromate. Cinnamon that was used to make apple juice type children products, applesauce products flavored with cinnamon, and the cinnamon was contaminated with lead chromate. Remember that the absorption of lead from the stomach in adults is less than in children. And of course, anemia itself or low calcium levels or zinc levels can increase the absorption in children. This is why often when you have a child with lead poisoning, we recommend giving them iron supplementation, calcium supplementation, multivitamins. That's one of the effective ways to reduce the absorption of lead and reduce the blood lead levels in children. So you can't emphasize this enough. And I think Dr. Geller, who was my professor when I was doing my fellowship at Emory, he taught me to rely on these. These are very important interventions in children with elevated blood lead levels. So don't underestimate those interventions. Of course, children can also inhale lead, or adults can inhale lead to their lungs, especially if it's in dust, a respirable type size particle. As Dr. Geller said, it's transplacental transmission is there. Skin absorption is not there unless there's some sort of solvent where the lead is in it that carries it through the skin. We mentioned already that lead ends up getting stored in bone, and that's your main bone, is your main storage compartment. And this is why when you remove the source of exposure, it's going to take some time for the blood lead level to decrease. It may be months and years before it goes back to a blood lead level that is less than, let's say, 5 microgram per deciliter. Why is lead a problem? Because it causes toxicity to multiple organs, and I will not spend too much time on this. These slides will be available on the Menatox website for those who want to go look at them at a later time. But it has multi-organ effects, including the bone marrow and heme synthesis. But essentially, the effects on the body are in multiple organs. And as the blood level increases, whether in adults or children, you will see more and more significant clinical effects, and patients will become more symptomatic, clinically symptomatic. It's important to remember that majority of people with lead in their body that's going to be causing these clinical effects may not come to you in an overt way because they may have subtle findings. So this is why screening is important. Whenever you have a disease that is subtle, you screen for it. Same for acetaminophen, which is initially doesn't cause significant symptoms. We send acetaminophen level on all our acute overdose. So that's kind of where we would like to end up going with lead in terms of universal screening, because the symptoms can be subtle and the effects still there. And you'll see that in rare cases, we see the encephalopathy patient. And these are the really life-threatening emergency that we can see in children with blood lead levels between 70 and greater than that microgram per deciliter. Typically, these people will come in with a seizure, with coma, altered mental status. They would have had maybe some preceding signs and symptoms of illness. Maybe for a week, they were feeling tired. They were having some abdominal pain. They were not eating very well. But again, something happens and the toxicity progresses to encephalopathy, and they come in life-threatening condition. And seizures, again, can happen as a one of the premonitory signs, but progress to coma and delirium. And that can lead to increased intracranial pressure and severe outcomes on the brain and the recovery of the children. The mortality from lead encephalopathy, luckily now has decreased from 20% years ago to less than 5%, probably because of the use of intensive care resources, maybe because of the use of IV chelation with calcium disodium EDTA and British anti-Lewisite. But at the same time, like I said, these children can be very sick and can be left with long-term neurologic effects and deficits. As your level goes down, you may start seeing less overt symptoms that may be missed. And if the exposure is not stopped, they can progress to encephalopathy. The biggest chunk of children will have the blood levels less than 50 microgram per deciliter. And these are the ones that are really hard to detect unless you're looking at their mental development, their cognition, their behavior, their fine motor coordination. They may have impaired hearing, impaired growth, short stature, and relying on hypochromic microcytic or normocytic anemia, this is not very reliable because you won't see this till you have elevated blood levels in the 50s or 40s. So again, this is not an early marker. So I know sometimes you rely on this to check a blood level, but I would recommend, again, the universal screening to find these children at levels of 30, 20 microgram per deciliter that require intervention. Because blood lead levels are associated with a drop in the IQ, and this is happening at very low blood lead levels, not even these 20 and 30. Of course, it happens at those levels, but the effect on the cognition and the IQ is going to be more severe at these lower blood lead levels. As we saw in the studies that looked at this, you find that blood lead levels between 5 and 10 microgram per deciliter will have a steeper effect on the IQ than blood lead levels greater than 10 microgram per deciliter. This is why we say today that there's no safe blood lead level. And even at blood lead levels below 5 microgram per deciliter, we believe that there are some effects on the health of the child and the mental development. I don't know if Dr. Geller want to comment on this a little bit here, because this is something that you've seen as a pediatrician and as an expert in environmental health.
Thank you. So the first thing to recognize here is that this is a population average. Different people are genetically different. And so the impact of a specific blood lead level on one person may be different than the impact of the same blood lead level on another person. So to follow the comment of our esteemed colleague, Dr. Ramu, who said that he didn't know what his blood lead level was, and maybe if he'd had a lower blood lead level, maybe instead of just being director, he'd be Grand Poobah or I don't know what. But I'm in the same boat. I grew up in New York City in the 1950s, in which time the average blood lead in the United States was in the 20s. And maybe I would be even better if I was having a lower lead level way back when, but nobody knows. But it might have made very little impact. Some people are going to have very profound effects comparatively compared to others. But the bottom line is that there is no good lead level. And so whether lead has a major impact on you or a minor impact, it certainly isn't making anything any better. And so the estimates of how much loss there is as societal level is associated with IQ loss, and whether that IQ loss is impactful or very impactful, it's not good. And so there are various estimates of how much blood lead you lose, how much IQ you lose at a given blood lead level. But the bottom line is that societally, as a big group, taking it as an average, there is huge losses from lead, and there is no good lead level. So trying to reduce the level of lead is good. And we also need to recognize that your impact now will have an effect over time as well as now, because you will have rebound since blood is retained in the bone. As your bone turns over, some of that lead that is stored in bone will come back into the circulation. And so you will invariably have rebound of lead going back up after you drop it acutely. and you will probably want to do another course of chelation eventually to try and remove some of that lead that rebounds into the blood, depending on how much it rebounds. So hopefully that's a helpful statement. But the one thing I would have you remember is that if I can make one point out of this, it's that the slide you had before, Kazzi, of showing the decrease in blood lead doesn't necessarily apply to every child. It applies on a societal average. And so some children will have more impact from the lead of 5 than other children.
Thank you.
And thank
And
you.
hold your thought together on that, because I want to bring you back to talk about the rebound and all that. So that's also going to affect, it's going to be related also, or be affected by whether this is an acute exposure or a chronic exposure we're dealing with. But I will move forward just a little bit to the adult population that can also get encephalopathic. I do want to say that the colic is interesting. You know, this is usually, the abdominal colic is usually at elevated blood lead levels. So this is not something that we expect to see at blood lead levels of 10 or 15 microgram per deciliter. We do see neuropathies, motor neuropathies. I've had the opportunity to see one patient with a motor neuropathy from lead exposure from paint occupation as a painter. We do see the pallor, the nephropathy. And again, going back to the lead colic, it's usually at severely elevated blood lead levels. It's usually severe recurrent abdominal pains. They last minutes to hours. They recur. They can be associated with marked obstipation, and the pain decreases by external pressure. This is some of the stuff I want to just share with you that are interesting. Also, the improvement with calcium gluconate and, of course, chelation. In the lower blood level ranges for adults, you'll see some of the non-specific neurologic effects like headache, fatigue, insomnia, the neuropathy I mentioned, some of the non-specific GI effects, but not really those colics that we discussed, and then your nephropathy, and then some of the anemia, myalgias, muscle weakness, and arthralgias. At chronic effects of adults with lead poisoning, your fatigue, your moodiness. We talked about the neuropathy, infertility, hypertension, renal disease, cardiovascular disease, and dementia. Currently, lead is not considered to be, an IR category 1 or 2A or 2B. So we don't have any evidence for cancer with lead. Of course, this may change as we get more data in the future. And some of the concerns in adults exposed to lead during their work is what is their risk of increased hypertension, kidney disease in this population. So this is some of the reasons why we consider more stringent occupational regulations to protect adults who are exposed to lead at work. Burton's lines is something that I've never seen, but it's something that you'll see with chronic severe exposure to lead. You see these blue lines over the gums. We talked about the reproductive effects in males and females. I don't want to belabor this at this point here. And lead in pregnancy, I think has been discussed already by Dr. Geller, but important to consider this because lead and pregnancy can cause adverse reproductive outcomes. And all of these can happen at blood lead levels in the 20s, or even there was one study between 10 and 20, we had some adverse effects. What is the prognosis of severe lead toxicity or lead encephalopathy in children? Like I said earlier, they can be left with significant neurologic sequelae. And same with adults, but they may have a better neurologic outcome than children. Oh, I'm sorry. I said that lead was cancer category 3. I was incorrect. It's actually 2B according to the EPA. So basically here it says probable human carcinogen. This is revised. In the past, before that, it was not classified, but now by the EPA, it's classified as 2B. Apologies for that error. So how do you assess and manage these cases? History is very important. So this is what I was calling on at the beginning of the need for everybody that encounters a case or does a study, a small study, to really pursue the source of these exposures and try to eliminate the exposure, because that's the most effective treatment, is eliminating the exposure. And to test the patient for their lead level, There are two ways. There's the easy way with the capillary blood test that I mentioned earlier. Now, the issue with the capillary test is that the skin can be contaminated with lead, and therefore, if you don't take proper precautions, you may have a falsely elevated lead level if you use a capillary test. The advantage here is that you are using a point of care machine. The lead care analyzer is what I've used, and the test is relatively inexpensive. It's less than $20 to do, and it gives you a result rapidly if you go ahead and perform the test right there. However, if it's elevated, then you may want to consider rechecking it with the gold standard venous blood sample using the ICP-MS or the GFAS, graphite furnace atomic spectrometry test. So either the ICP-MS or GFAS are the gold standards using a venous blood lead level. So that's something to remember about the capillary versus the whole blood, venous blood testing. Dr. Gary, you want to comment on this a little bit?
Sure. When people present to me with a capillary blood test that's elevated, I'd say 80% of the time or higher, a repeat venous sample shows it's not elevated. So it's a good screening test. It's not a diagnostic test. You really need a venous sample to get before you're going to go engage in treatment that's expensive and tedious. So I definitely would say capillary screening is great, but if it comes back elevated, it needs a repeat venous sample. The false positive rate, I don't know, a couple of percent, but of those that come back positive, 80% will be abnormal. 80% will be false positive, I mean. So I definitely agree with this.
That's a quite high number you're quoting together.
My personal experience, I can't tell you that, but it's a very high number, very high percentage of the capillary tests that are elevated come back contaminated. But it's a small percent of all tests. If you figure that 95% come back reassuring, and then you repeat the 5%, you'll get down to 1% that are abnormal out of those tests in our experience here. In a population that has a higher underlying prevalence, all those numbers will be higher. But still, I would not proceed to treat based on a single capillary test.
Thank you. Yeah, and of course, it also depends what is the average blood level in the population. You know, I think that the differences between a capillary and a venous blood sample would not be very large, correct, altogether?
So if the skin were perfectly clean and never contaminated, the numbers should be the same. However, there are times where the sample is contaminated for whatever reason. You need to remember the volume of blood we're playing with and the small percentage of lead that's in that means that a very small amount of contamination can make a significant difference. A capillary sample is probably testing less than 100 microliters of blood. I didn't say that wrong. I meant that. That's 0.1 mLs of blood. And so having a very small one particle of contamination in your 0.1 mLs of blood can make a significant difference.
Thank you. So that's something to remember, that your capillary testing is good for the screening method and has to be confirmed when it's positive with the whole blood, venous blood, ICP-MS, with care taken not to use tubes that are contaminated themselves with lead. So that's the other thing. You have to make sure your lead-free tubes are being used for the collection of the blood sample. Now, you could use the erythrocyte zinc protoporphyrin test. This is an adjunct test, just to kind of help you understand how recent the exposure to the lead has been. For example, if you have an elevated blood lead level and a normal zinc protoporphyrin level, that means it's a recent exposure. As time goes by, a few months, you can start seeing the elevation in the ZPP, which is how you use this adjunct test. We don't recommend checking lead in urine, and we don't recommend checking lead after chelation. Please, these are not reliable, not validated, and not to be used. You, as a passionate and advocate to lead poisoning prevention, you should advocate for not using these tests. X-ray fluorescence sometimes comes up. It's more of a research tool, but sometimes comes up with some patients that ask to receive an X-ray fluorescence test to see how much lead they have in their bones. Because like I said, since lead sits in bones, you can do a fluorescence test and look and see how much there is in the bone stored that's not necessarily in the blood, because they'll have a, let's say, a low blood lead level, and they're wondering whether they have a large body burden of lead and they want to test their bones. And they come to our clinic asking for this. Unfortunately, we don't have good validation of going from the amount of lead we estimate is in their bone to the clinical effects. This is why I personally hesitate to do this. But there are some studies, research studies, linking the bone lead content with adverse health effects, but not something that I can use in clinical practice. You can see also some basophilic stipplings, which are ribosomal fragments inside the erythrocytes. You see those basophilic stipplings, but these again are not specific to lead. They can occur with other heavy metal poisonings and other conditions. You can also see some arrest in the progression of the growth plate in children. This is for young children that have elevated blood lead levels. Takes some months to appear, but can sometimes serve as a clue in these young children with elevated blood lead levels. Managing the lead encephalopathy patient. Luckily, we don't see a lot of these, but occasionally we do. And when this happens, this is a life-threatening condition, like I mentioned. An IV chelation is usually preferred with British anti-lewisite and calcium disodium EDTA. If you don't have calcium disodium EDTA, you could go with Suxamer. There are some case reports where Suxamer has been used. But in this case, calcium disodium EDTA is preferred. The BAL, the British anti-lewisite, is given before the calcium disodium EDTA IV infusion is started by 4 hours to prevent the redistribution of lead into the central nervous system if you don't use the BAL and just use the calcium disodium EDTA. So starting with BAL, 4 hours later, you'll start the EDTA and then continue with BAL every 4 hours as you are infusing the calcium disodium EDTA. Remember to use the calcium disodium EDTA as opposed to the sodium EDTA, which causes life-threatening hypocalcemia. So remember, you have to use the calcium disodium EDTA, which prevents this life-threatening condition of hypocalcemia that can complicate the use of disodium EDTA. Suxamer is easier to use, I would say. It is, of course, oral. It does have a bad taste. It is going to require, of course, oral administration, and it may cause some minor side effects, GI upset, slight bump in the liver function tests, slight bump in the kidney function tests, but nothing significant, in my opinion, my experience, to warrant stopping it. And you give it for 19 days. And I don't have time today to go over the dosing recommendations that you can pull up, but definitely more available than calcium disodium EDTA, and still sometimes not as available. Dr. Geller recommended oral deep penicillamine as well. British anti-lewisite intramuscular injections can be complicated. They can be painful. They can also cause some adverse reactions. The last time I used British anti-lewisite here at Grady for a patient with mercury poisoning, we had to stop it because he developed fever, rigors, vomiting, and could not tolerate it. So we had to stop it and switch to Suxamer in that case. I don't know, Dr. Geller, you want to say a few more things about treatment before we talk about rebound and talk about, kind of patients?
So when you're faced with a shortage of all the chelators are in short supply in the United States and worldwide. So you have to be flexible. And my assumption is that one treatment moiety is better than no treatment moieties. So if you have to choose between what you can get and what you can't get, I'd think seriously about what you can get. The only caveat to that is when you have lead encephalopathy, you cannot give calcium disodium EDTA alone because you have the potential of creating more redistribution into the brain and making things worse before you make them better. But except for that one situation, I would choose whatever I could get my hands on if I could get my hands on only one drug. Those are your choices.
And I want to just emphasize here the need for GI decontamination, especially with children that have pica behavior and may have their stomach full of, or intestine full of lead paint chips. Also, we have the occasional child that ingests a lead foreign body, a leaded bullet or a lead fishing weight sinker. So these are all specific situations. So getting an X-ray of the abdomen is important. Also, particularly if you're doing oral chelation, you would like to get an X-ray to make sure that the abdomen is free of any lead foreign bodies. Also, remember to use your other adjuncts, like I said, your iron supplementation, calcium supplementation, zinc supplementation. I want to now take us to another situation, which is more complicated, yet more common. Those children that have blood lead levels of less than 45 microgram per deciliter, and whether this treatment here is warranted. I do want to also ask permission to take an extra 10 minutes of your time and stop at 10:10, at 11:10 Eastern time. So 10 more minutes if it's okay. If you have to leave, we understand. But this is being recorded, and I'm just going to go through some of the last complex scenarios. Is that okay with you, Dr. Ramu?
That's okay with me. I have to unfortunately hop off for another meeting in 10 minutes, but it's recording on my computer, so hopefully that won't be an issue.
Okay, thank you. So again, so the issue with blood lead level less than 45, this is your biggest chunk of patients. And of course, when you're not encephalopathic and you have a blood lead level greater than 45 microgram per deciliter and you want to treat, of course, Succimer there is preferred. But when you're below 45 microgram per deciliter, what is the evidence that we have for this? Again, in these cases, you can consider giving the Succimer, but unfortunately, the clinical benefit on cognition in children has not been, proven. So that's the issue that you have to decide on. Remember that a typical course will only decrease your body burden of lead by 1 to 2%, especially if you're chronically exposed to lead. And you may not be able to have a positive effect on your cognitive function. Just want to show here a picture of paint chips in the intestinal tract. This is where, giving whole bowel irrigation is important before you start chelation. And just want to turn it over here to Dr. Geller to talk a little bit about the TLC study.
So this is the best single study. It was done in a group of children in 3 urban areas that presumably had a higher prevalence of lead poisoning, and demonstrated that children who were chelated did drop their blood lead transiently. The blood lead by 9 months after therapy rebounded to the same as in the treated group as in the untreated group. So you had a 9-month benefit. There was substantial follow-up done, and they showed no effect. However, the question is fair as to would it have mattered if you had kept their blood lead level lower and by recurrent course of treatment. That was not studied. Also important to note is that if you look at their scatter plot in this study, you will see that the scatter plot shows that some children had more impact than others from their high blood lead level.
Which brings us back to what you made earlier, Dr. Geller, about individual variability in the...
Yes, people are different. The other thing is that the study was stated that there was not enough power in the study to test the post hoc hypothesis that a child who was treated at a younger age would have more impact from the chelation. Therefore, that statement is unknown. So if you're inclined to treat at a lower level, it makes sense in my mind, but there is no evidence to prove or disprove that treatment makes a difference at a lower age.
And
so I'll turn it back to you, Kazzi.
No, thank you. I appreciate your expert comments, Dr. Geller. And I learned that from you, and I actually follow your guidance on that, and I follow your school of thought, especially that, if the chelating agent is available, if the Succimer is available, we know the side effects are minimal, and if the resource is available, and especially if the exposure is new, and I stop the exposure, if I remove the child from the exposure, and I know there's nothing in the intestinal tract currently, and especially if this is a recent exposure or a young child, if lead has no use in your body, if you can remove some of it out with potential for recurrent treatments, recurrent courses, I think this is worthwhile. Say you're a pregnant patient, and or I'm not sorry, a woman of childbearing age trying to get pregnant and has an elevated blood lead level. I mean, I think that will optimize potentially her chances for a healthy outcome for a pregnancy, for a future pregnancy. But this is kind of the toughest situation to discuss and deal with when you are dealing with patients with lead poisoning. This is your most common patient, not your encephalopathic patient where the decision is easier. I don't know if others on the call have something to add on this. And if not, we can maybe conclude this with taking some questions and answers from the chat. I think we have a question from Dr. Sudan Karki about what sort of spices are we talking about here? Usually, the spices that were in Georgia, at least, contaminated, were spices that were manufactured by traditional markets, not necessarily by commercial sources. But again, it can be also commercial sources, so it's not something that you can exclude. Typically, the spices have orange or yellow color, for example, like turmeric, where lead chromate is used to make the color more vivid. It's also can help with the weight. So this is some of the reason why these contaminations happen. Dr. Basita Shah, please go ahead.
Yes, I have some queries like recent study from India, Bihar, which is in border with Nepal, Tarai region, had a study done collaborating with Vital Strategies Pure Earth NGOs from Newark, USA and Germany, and local research center of India. They had this data of 700 children and 55 pregnancy whom were almost 90% to 80%, more than 80% cases were having more than 5 microgram per DL lead. So is there in Nepal case, is there burden mapping done of lead? And other questions were like, because in Nepal also, in Kathmandu, within valley, there are like waste collectors and battery centers which are not at their, that par of occupational, they are not following that occupational hazard, like Exide, Battery and Luminous. And are there any preventive strategies currently going on in Nepal also? And what about the subclinical cases in case of Nepal? What are the prognosis and their percentage and levels? If those are the questions. Thank you.
Thank you so much for participating. Can you repeat before we answer your question? What was the result in Bihar?
Yeah, there were the result was quite horrifying. About almost around 697 children were participated, more than 90%, and 55 pregnant women. There were more than 80% were found having 5 microgram per DL lead level.
What about if you look at higher blood levels for these pregnant women, like 10, if you lose a 10 microgram per deciliter, what percentage would that be?
The study was, the results of the study was limited to that.
It'd be interesting to look at higher blood levels for these pregnant women.
I will leave the link here in the chat of that study.
Yes, thank you. Maybe Dr. Ramu, can you answer the question about Nepal? Otherwise, I can summarize what we talked about earlier.
Sorry, Kazzi, can you summarize the Nepal specific question?
The question was, have you done national surveillance in Nepal? Like, do you have a national study like this, like the one in Bihar? And then, what are the subclinical effects? What are the clinical effects that you've noticed in these patients in Nepal?
Right. Thank you, Dr. Basita. There actually, we had presented a few 3 or 4 studies that were done over the last 3-4 years in different areas of the country. So there was a large, like I think 330 patients a pediatric patient study that was done around the Kathmandu area that showed 65% of children with blood lead level that was greater than 5. And then there are some studies from Birganj, which is a place that's, Dr. Samir Kumar said earlier, of high industrial importance where blood lead level was high. So there are some studies that are done sporadically. I haven't found sort of a national level study that has been done, which I think does need to be done, and that's something that we've been talking about as well. As far as the, I'm not a clinician that practices in the country, and from our poison center, we have, Dr. Rajesh has presented one of the cases there, but Dr. Ananta had mentioned earlier that, from his GI clinic, he sees quite a bit of acute toxicity lately that are coming with GI complaints. So that's all I'll say about that aspect.
Thank you, Dr. Ramu, and thank you for your intervention. Any other questions? You can raise your hand. Like I said, I'll make those slides available on our website. We will use the registration list that we have for the Zoom webinar today that Dr. Ramu can provide to also provide a link to the recording. I want to just thank you on behalf of Menatox, Emory University, and the Oman Poison Center for joining today. I'd like to turn it over for final concluding remarks to our colleagues in Nepal. And I bid you a good evening or good day if you're on the Eastern time like myself.
Thank you, Dr. Kazzi. And really, thank you a lot. Thanks to everyone that joined today. This was a very special session for us. As you know, the Nepal Poison Center has been doing webinars every month with international experts on various topics that are pertinent to the country. And this topic in particular is not only pertinent to our country, but to so many other countries that we have seen today. We have representatives here from Nigeria, Oman, Iraq, Lebanon, United States, and India. We've seen so many different sort of aspects of presentation and sources of lead poisoning and how this is a huge public health burden that we all need to sort of work together thinking of solutions that can work even in rural settings as well as settings that have low resources like ours in Nepal. So I specifically want to thank Dr. Kazzi, who kind of led this, participants and made this happen. So thank you so much. Thank you to the WHO for doing this week and kind of the international audience that have joined us here. I want to thank my colleague in the Nepal Poison Center, who some of them are here, some of them are not here. Thank you to Dr. Badria from Oman. Thank you to Dr. Geller. The list goes on and on, so I'm going to stop naming people, but this will be available on YouTube. That will have this shortly in a few hours today. And really continue joining the Nepal Poison Center efforts, and we'll see you at Menatox hopefully in February. With that, I would like to say thank you and goodbye.
Thank you.
Bye-bye.
Thank you, everybody. Bye.
Bye.
Bye.